Imagine a time when going under the knife was almost as dangerous as the disease itself. For centuries, the biggest enemy in surgery wasn't always what the surgeon could see, but the invisible ones you couldn't.
Yeah, exactly.
We're talking about infection. The battle against microscopic invaders, especially when the body's natural defenses are breached, has been, well, a fundamental human challenge since we first tried to heal with our hands.
Absolutely. And you might think with all our modern technology, we'd have this licked. But surgical infection remains one of the deepest, most complex challenges in medicine, despite, you know, centuries of relentless effort and incredible progress.
And that's why we're here. Today, we're doing a deep dive into this vital topic. We're pulling back the curtain using a truly foundational source, a classic text that's shaped surgical thinking for generations.
Our mission together is to unpack everything this source lays out about surgical infection. We'll go from the tiniest microbes that cause the trouble to how your amazing body tries to fight back, how we've learned to prevent these infections, and the strategies we use when they do take hold.
Right.
By the end of this deep dive, you won't just know facts. You'll have a level of understanding that's essential for anyone who truly wants to master this landscape. Let's get started.
Okay, let's unpack the history because this is a fight that goes back thousands of years. We're talking ancient civilizations. You mentioned efforts to prevent decay, even in things like mummification using salves, antiseptics.
That's right. The Egyptians were doing this way back, popularizing ideas about preventing putrefaction. The Assyrians knew similar things, and the Greeks later described using salves and antiseptics for wounds independently. It shows this kind of intuitive understanding that something needed to be done to prevent things from going bad when tissue was injured.
And this idea of dealing with what looked bad on a wound led to a widespread principle, didn't it?
It did. Across all these ancient civilizations, Egyptians, Assyrians, Greeks, Romans, there was this enduring belief that if there was localized pus, it had to be drained. Hippocrates, for instance, he recommended irrigating infected wounds with wine or vinegar before eventually closing them.
Which brings us to Galen, the famous Roman physician who worked with gladiators. He saw wounds that produced pus drained and then healed. He even called this pus bonum et laudabi, good and laudable pus. It sounds, well, bizarre to us now, associating pus with a good outcome.
It does, because our understanding has shifted so dramatically. But in the context of contaminated arena wounds, seeing that localized inflammatory response and drainage often meant the infection didn't spread systemically. It was, in a way, contained.
Right, containing the damage.
Compare that to later thinkers like Theodoric of Servia in the 13th century, and then Ambroise Paré and Guy de Chauliac centuries later. They started observing that clean, primarily closed wounds could heal beautifully without any pus or infection whatsoever.
Ah, so a direct contradiction almost.
Well, a quiet challenge, certainly, to Galen's long-held idea. It suggested a different path to healing was possible.
But the real breakthrough came in the 19th century when we finally started to understand what was causing the problem. This is where we get Koch's postulates. This was fundamental, right?
Absolutely, Evie, foundational. Robert Koch gave scientists a rigorous framework for proving that a specific microorganism was the cause of a particular disease. He laid out 4 criteria.
Okay, what were they?
First, the organism must be found in every single case of the disease. Every single one. Second, you must be able to isolate that organism from the diseased host and grow it in a pure culture outside the body.
So grow it in the lab.
Exactly.
Yeah.
Third, when you introduce that cultured organism into a healthy, susceptible host, it should reproduce the original disease. And fourth, you must be able to recover the organism from that experimentally infected host.
That's powerful because it established a direct, verifiable link between a specific bug and a specific illness. No more guesswork.
Precisely. And while Koch was working on that, you have the incredible simple revelation from Ignaz Semmelweis.
Semmelweis' story is stark and dramatic, isn't it?
It really is. Working in Vienna in the mid-1800s, he saw a horrific death rate from puerperal sepsis, a deadly infection after childbirth, in the division where doctors and medical students attended deliveries right after performing autopsies.
Without washing their hands.
Right. In the adjacent division, where midwives worked and didn't do autopsies, the death rate was much, much lower. His incredible insight, despite being ridiculed at the time, was that something unseen was being transferred from the cadavers to the mother's birth canals.
And his solution was almost laughably simple by today's standards.
Simple hand washing. He implemented a policy of washing hands with chlorinated lime solution between examining patients, especially after autopsies. And the death rate plummeted from over 10% to under 2%. He demonstrated that infection was being carried by unseen agents transferred by people.
So you have Kekalik proving the specific link, Semmelweis showing how something unseen is transferred.
And then the overarching theory from Louis Pasteur.
Germ theory.
Yes, Pasteur's germ theory provided the foundational understanding that microorganisms cause disease in the first place.
Okay.
And then Joseph Lister was the one who brilliantly applied this directly to surgery.
He tackled compound fractures, which were almost always fatal from infection back then. A death sentence, really.
Exactly. Lister used carbolic acid, a chemical antiseptic, to sterilize instruments, dressings, and even tried to sterilize the air around the wound during surgery. His idea was to reduce the number of these germs in the surgical environment. This was a revolutionary step, bringing the fight directly to the microbes in the operating room.
So Lister was about killing bacteria already present antiseptic technique. The logical next step was, well, to stop them from getting there at all, right?
That's the move to aseptic technique, which really took hold around the turn of the 20th century. Aseptic technique is about creating a sterile environment and preventing microorganisms from contaminating the surgical field in the first place.
It's proactive rather than reactive.
Precisely. This involves rigorous processes that are still the standard today. Meticulous hand scrubbing, sterilizing instruments, using sterile gowns, gloves, drapes to isolate the surgical site. It's about absence, not just destruction. You see this depicted in modern operating rooms, like in Figure 5.1 in our source material.
This whole journey sets the stage for the next revolution: antibiotics. The idea of a magic bullet, something that could kill bacteria inside the body without harming the patient, started becoming a reality in the mid-20th century with drugs like sulfonamides.
And then came penicillin. Alexander Fleming's discovery in 1928 was serendipitous, wasn't it?
Yeah.
Observing a mold that inhibited bacterial growth.
The famous contaminated petri dish?
Right. But it was the painstaking work of Howard Florey and Ernst Chain in the early 1940s to isolate and purify penicillin for clinical use. This was truly transformative.
How did penicillin change surgery? I mean, really change it?
It changed everything. Before penicillin, many surgeries were simply too risky because the inevitable bacterial contamination, especially in abdominal surgery, meant almost certain death from infection. Penicillin allowed surgeons to perform procedures that were previously unthinkable, saving countless lives.
But this miracle also brought a new inherent challenge: resistance. It's almost like Newton's third law for medicine.
It's the flip side of the coin, exactly. Bacteria are incredibly adaptable. They evolve mechanisms to survive exposure to antibiotics. It's an ongoing biological arms race. One of the most common ways they do this is by developing enzymes that break down the antibiotic molecule itself.
Like galactomases, I remember that term.
Exactly. Galactomases are enzymes that specifically target the dry lactam ring structure found in many commonly used antibiotics like penicillin and cephalosporins. The bacteria produce this enzyme, and it basically chops up the antibiotic before it can do its job.
And our source highlights a particularly concerning version of this: ESBLs.
Ah, yes, extended spectrum lactamases. As the name suggests, these enzymes break down an even wider range of bilactam antibiotics. They are a growing problem, particularly in gram-negative bacteria that commonly cause infections like UTIs. When these bacteria produce ESBLs, it makes the infection much, much harder to treat with standard antibiotics.
And you mentioned MRSA as a major concern in general surgery. That one gets a lot of press.
It does, and for good reason. Methicillin-resistant Staphylococcus aureus. Staph aureus is a very common culprit in surgical wound infections and infections related to prosthetic implants. Many Staph aureus strains produce beta-lactamase, making them resistant to regular penicillin, but MRSA strains are resistant to an even broader group of penicillins, including methicillin and flucloxacillin. This limits treatment options significantly.
Where does MRSA typically come from in a hospital setting? Is it just everywhere?
It can be carried asymptomatically in the nose and throat of both patients and healthcare workers. About 30% of people carry Staph aureus, and a smaller percentage carry MRSA without knowing it. This makes it easily spread within the hospital environment, unfortunately.
So some regions have found ways to keep MRSA rates low. I think the source mentioned that.
Yes, particularly in parts of Northern Europe, they often employ a search and destroy strategy. This involves actively screening patients electively admitted to the hospital to see if they're MRSA carriers.
So finding it before it causes a problem.
Exactly. If they are carriers, they can be isolated and treated to eradicate the MRSA before their surgery, preventing it from spreading to others or causing their own surgical infection. Hospitals also have specific local policies for managing MRSA based on prevalence, the type of hospital, specialty, available facilities. Things like patient isolation, screening staff, and rigorous disinfection protocols are all part of it.
It's fascinating how antibiotics made incredibly complex surgeries possible. The source mentioned primary wound closure in over 90% of patients with heavily contaminated fields like fecal peritonitis.
Yeah.
That sounds like a huge leap from leaving everything open.
It is. It's a massive leap. Before effective antibiotics and modern critical care, these kinds of scenarios were almost uniformly fatal. The ability to use antibiotics to suppress infection allows us to contemplate and successfully perform surgeries that were impossible just decades ago.
But you also mentioned in the source notes that leaving wounds open is still sometimes the better option. It's not always about closing things up neatly.
Absolutely. While primary closure with antibiotic support is possible in many contaminated cases now, for heavily contaminated or truly dirty wounds, delaying closure, what we call delayed primary closure, or leaving the wound open to heal by secondary intention is still considered best practice.
Why is that?
It allows the body's own defenses and, importantly, drainage to clear infection before attempting to close the tissue layers. This balance between closing and leaving open is a crucial surgical judgment call, often guided by the degree of contamination and the patient's condition.
Okay, let's get specific about the enemy. Our source gives us a rogues gallery of the microbes most commonly causing trouble in surgery. Where should we start?
Let's start with the Streptococci. If you looked at them under a microscope, they'd look like little chains of spheres, and they stain gram-positive.
Which ones should we really know about in surgery? Are they all equally bad?
The most feared is the beta-hemolytic Streptococcus, particularly Lancefield group A, which is Streptococcus pyogenes. This one often lives harmlessly in the throat, but if it gets into a wound, it's dangerous because it spreads fast.
Why so fast?
It produces enzymes like streptolysin, streptokinase, streptodornase. These break down tissues and help it spread. It's a major cause of rapidly spreading cellulitis and can cause significant tissue destruction. Other streptococci, like Streptococcus faecalis, which is now called Enterococcus faecalis and is in group D, often act in nasty combinations synergistically with other bacteria. And there are anaerobic ones too, like Peptostreptococcus.
But not all streptococci are wound infectors. I think the source mentioned one specific type.
Correct. The alpha-hemolytic Streptococcus viridans, for example, is a common mouth inhabitant, but is specifically noted as not being associated with wound infections. The good news, relatively speaking, is that most clinically significant streptococci are still sensitive to plain penicillin.
So penicillin is still a workhorse there.
Very much so. Erythromycin and cephalosporins are good alternatives if someone has a penicillin allergy.
Next on the list, Staphylococcus.
They look different under the microscope.
Oh, right.
They do. Staphylococcus look like clumps of spheres, sort of like bunches of grapes, also gram-positive, and they're classic pus producers or pyogenic bacteria. The big one is Staphylococcus aureus. It's another common resident, particularly in the nasopharynx, the nose and throat area.
And it's a main character in wound infections and infections around implants, like artificial joints or heart valves.
Exactly. And of course, this is where MRSA comes in again, the methicillin-resistant Staph aureus we discussed. Dealing with Staph aureus often requires antibiotics resistant to beta-lactamase, like flucloxacillin if it's not MRSA. For MRSA or more serious S. aureus infections, we need different drugs like vancomycin, ticaplanin, aminoglycosides, or some specific cephalosporins.
You mentioned newer, more expensive antibiotics for resistant strains earlier. The source named a few.
Yes. Our source points out things like linezolid, which has an oral form, which is very useful for stepping down IV treatment, later ticaplanin, which has wide gram-positive coverage, and daptomycin, which is particularly good for bloodstream infections, bacteraemia. They are powerful tools against resistant strains, definitely.
But they come with caveats.
They do. They are expensive. They can have significant side effects, toxicity to bone marrow, liver, kidneys, and their use is usually, and quite rightly, restricted by hospital policy and guided by microbiologists to preserve their effectiveness and manage costs.
And there's a relative of Staphylococcus that used to be considered harmless, kind of dismissed.
That's the coagulus-negative Staphylococci. The most common one is Staphylococcus epidermidis, which used to be called Staphylococcus albus. It's a very, very common bacterium living all over your skin. For years, it was mostly dismissed as just a contaminant if it showed up in lab samples.
But not anymore, especially with implants.
Not anymore. In the era of implants and indwelling catheters, it's become a major headache.
Why is that? What changed?
Because it's a master of forming biofilms. Imagine a sticky, protective slime layer that bacteria create on artificial surfaces like a prosthetic heart valve, a hip replacement, or a central venous catheter. The bacteria embed themselves in this slime.
Like hiding in a bunker.
Kind of, yeah. And it makes them incredibly difficult for antibiotics or the body's immune cells to reach and kill. Staph epidermidis is particularly good at forming these biofilms. So, what was once considered harmless is now a major threat in vascular and orthopedic prosthetic surgery.
That sounds like a real challenge. Okay, let's move to the anaerobes, the ones that live without oxygen. Clostridia.
Right, these are gram-positive rods, and critically, they are spore formers. These spores are incredibly tough, resistant to heat and many disinfectants, which makes them very hard to eliminate from the environment. They live where there's no oxygen.
And the classic names here are?
The classic names are Clostridium perfringens, infamous for causing gas gangrene, and Clostridium tetani, the cause of tetanus.
And the one we hear about causing hospital outbreaks, particularly linked to antibiotic use. Clostridium difficile.
Ah, C. diff, yes. This causes a serious gut infection called pseudomembranous colitis. It usually happens when antibiotics, especially broad-spectrum ones, wipe out the normal, helpful bacteria in your gut, the gut flora.
Creating an opportunity.
Exactly. This allows C. diff, which might be present in small numbers as a harmless commensal, to overgrow and start producing toxins that damage the colon lining.
Which antibiotics are most likely to cause this? Is it all of them?
While any antibiotic can potentially trigger C. diff overgrowth, our source specifically mentions quinolones, like ciprofloxacin, as being particularly high risk. And the risk is higher in vulnerable patients like the elderly or those with weakened immune systems.
And the infection itself can be severe. It's not just diarrhea.
Oh, it can be horrifyingly severe. In the worst cases, it can lead to perforation of the colon, requiring emergency surgery to remove the entire colon, a total colectomy, and it carries a high risk of death, even with surgery.
How is it treated and diagnosed?
Treatment involves stopping the offending antibiotic as possible, aggressive fluid resuscitation, and giving specific antibiotics against C. diff, usually metronidazole or oral vancomycin. Diagnosis is now much faster with rapid tests that can detect the bacteria's antigen, GDH, or the toxins AB directly from a stool sample using lateral flow tests, often giving results in less than 30 minutes. You'd often start an empirical treatment while waiting for confirmation if suspicion is high.
Let's talk about the aerobic gram-negative bacilli. Where do they usually live?
These are common inhabitants of the large bowel. Think Escherichia coli, E. coli, Klebsiella, those are lactose fermenters, and Proteus, which doesn't ferment lactose.
And they cause trouble after bowel surgery.
Very often. They often work together in synergy with anaerobes like bacteroids to cause serious surgical site infections, especially after operations involving the bowel like appendicitis, diverticulitis, or peritonitis. And E. coli is also the #1 cause of urinary tract infections, particularly associated with catheters.
And these are also susceptible to that ESBL problem we talked about earlier.
Unfortunately, yes. The spread of ESBL production among these gram-negative bacteria is a significant and growing concern because it makes many standard antibiotics, particularly many cephalosporins, ineffective against them.
Pseudomonas species are another type of gram-negative bacteria mentioned. Where do they tend to cause problems?
Pseudomonas species often colonize moist environments. You find them in places like burns, tracheostomy wounds, and the urinary tract, especially in patients who have been in the hospital for a while. Hospital strains can be very persistent and difficult to get rid of once they've established themselves in a unit. Surveillance is really important.
And resistance is an issue.
Yes, resistance spreads easily via plasmids, and they often produce beta-lactamoses. Antibiotics are generally only needed for Pseudomonas wound infections if the infection is clearly spreading or the patient has systemic signs of infection. Effective treatments include aminoglycosides, quinolones, and some carbapenems like meropenem, but resistance patterns need careful monitoring as they can be resistant to some cephalosporins and penicillins.
Finally, the bacteroids. Anaerobes again.
Yes, these are non-spore-bearing strict anaerobes, meaning they absolutely cannot live where there's oxygen. They are major inhabitants of the large bowel, but also found in the vagina and the oropharynx.
And the main one in surgical infections.
Bacteroides fragilis is the main culprit. As we mentioned, it's notorious for working synergistically with those aerobic gram-negatives like E. coli to cause nasty surgical site infections and intra-abdominal abscesses, particularly after colorectal or gynecological surgery. They're usually sensitive to midazoles like metronidazole, and some cephalosporins like cefotaxime also have activity.
That's quite the lineup of microscopic foes. So, with these players in mind, How exactly do surgical infections get started, and what makes someone more likely to get one? It's not just bad luck, is it?
Not usually, no. At its core, a surgical wound infection happens when microorganisms invade tissues after the body's natural defenses are breached by the surgery or trauma. This can lead to localized issues like cellulitis or an abscess, or spread more widely, even into the bloodstream, causing bacteremia.
And we classify these infections.
Yes, we classify surgical site infections, or SSIs, by depth. Superficial SSI involves just the skin and subcutaneous fat. Deep SSI involves the deeper soft tissues, like the musculofascial layers. And organ space infection involves any part of the anatomy other than the incision layers that was opened or manipulated during the operation, like an abscess deep inside the abdomen after an anastomotic leak or following perforated appendicitis.
And how do these pathogens get past our defenses? What are their tactics?
They have strategies. Many release toxins or enzymes that break down tissue, which helps them spread, particularly in areas with poor oxygen supply or dead tissue, necrotic tissue. We talked about Clostridium perfringens using enzymes like hyaluronidase and collagenase to spread through tissues and gas gangrene. And as we've discussed, they can acquire resistance genes, often on mobile genetic elements called plasmids, becoming much harder to kill with antibiotics.
Where do the bacteria usually come from? Our bodies are full of them, right? We're not sterile.
Exactly. Your body hosts trillions of microbes. Estimates suggest about 10 times more bacterial cells than human cells. These can be released into tissues during surgery, especially if you open a hollow organ like the bowel or respiratory tract. Our source classifies infection sources as either endogenous coming from on or in the patient themselves, their own flora, or exogenous coming from outside the patient.
Like the operating room environment.
Right, like the operating theater air, contaminated instruments due to failures in sterilization or aseptic technique, or even from the ward environment, later due to things like poor hand washing between patients. Hospital-acquired infections, HAIs, fit into this exogenous category often, or can be endogenous flora taking advantage of the hospital stay.
And which source is more common in modern hospitals with good sterilization?
Endogenous sources from the patient's own microbial flora are overwhelmingly the most common cause of surgical infections in modern hospitals. Exogenous sources, while less frequent thanks to better aseptic practices, are still important, especially when you see outbreaks of infections caused by the same organism.
Our bodies do have sophisticated defenses, though. We're not completely helpless.
Not at all. They're quite amazing, really. Your first line is mechanical, intact skin and mucous membranes, which are obviously broken by surgery or trauma. Then there are chemical defenses, like the low pH, the acidity in your stomach. You have humoral immunity antibodies, complement proteins, opsonins that tag bacteria for destruction, and cellular immunity involving phagocytes like macrophages and neutrophils, plus various types of lymphocytes, including killer cells, the cells that engulf and destroy invaders.
But surgery itself knocks down these defenses.
It does. Surgical trauma itself disrupts these mechanical barriers and can temporarily suppress or compromise other defense mechanisms as well, creating a window of vulnerability. Host, speaker, speaker. So whether an infection develops isn't just about whether bacteria get into the wound. It's more complicated. Much more complicated. It's a complex equation. The key determinants are, first, the pathogenicity or virulence of the bacteria, how inherently nasty is it? And second, the sheer number of them that get in, what we call the inoculum size.
But that's not the whole story.
Not at all. Crucially, it's also your host factors how well your body can fight back. Even a less virulent bug or a relatively small number of bacteria can cause a significant infection if the host's defenses are weak or compromised. Local tissue health matters enormously too. How good is the blood supply? Is the tissue healthy or ischemic? Is there dead or foreign material like sutures, mesh, or a hematoma present?
And the source adds one more critical determinant related to timing.
Yes, absolutely critical. The presence of effective antibiotics in the tissues during the decisive period. But before we dive specifically into that period, let's quickly list the specific patient and surgical factors that really increase infection risk, because there's a whole range identified in Summary Box 5.5.
Okay, lay them out for us.
Things like malnutrition, and that includes both being significantly underweight and obese. Metabolic diseases like uncontrolled diabetes, kidney failure, uremia, or jaundice. Patients with weakened immune systems from underlying cancer, AIDS, or receiving treatments like steroids, chemotherapy, or radiotherapy are definitely at higher risk.
What about gut health?
Yes, poor gut health or conditions causing compromised blood flow to the gut can lead to bacterial translocation, which we'll discuss more. Conditions causing poor perfusion overall, like shock or significant local ischemia, the presence of foreign body material sutures, drains, implants, and finally, something harder to quantify but vital, poor surgical technique that leaves behind devitalized tissue, dead space where fluid can collect, or large hematomas. All these create a favorable environment for bacteria.
Okay, let's circle back to the decisive period. This sounds like a really crucial concept for preventing infection.
It absolutely is. Our source defines it as a window of time lasting up to about 4 hours immediately after tissue is injured, either by trauma or by the surgical incision. This is the critical time before bacteria that have inevitably entered the wound start growing and multiplying enough to establish themselves and cause a clinical infection.
So if you're going to prevent infection with something like antibiotics, it has to happen during this narrow window.
Precisely. The central idea behind prophylactic antibiotics is that if they are present in the tissue at sufficient levels during this decisive period, they can kill or inhibit the bacteria before they get a firm foothold. If you wait until after this window closes, the bacteria have already started to multiply significantly, the infection process is underway, and prophylaxis is essentially ineffective. It becomes treatment, not prevention.
So the timing is everything.
Everything. You need antibiotic levels in the tissue that are above the minimal concentration needed to inhibit 90% of the expected bacteria, that's the MIC90, throughout this critical time.
So when is the optimal time to give prophylactic antibiotics to achieve that?
Intravenous administration right at the induction of anesthesia is considered optimal. This ensures the highest blood and tissue levels are present right when the incision is made and throughout the initial, most critical phase of the surgery. It also covers any unexpected delays that might happen after the patient arrives in the operating room but before the surgery actually starts.
Should they be repeated during or after the operation? Does giving more help?
Doses can be repeated, yes, but only under specific circumstances. During very long operations where tissue levels might fall below the MIC, if there's significant blood loss which washes out the antibiotic, or if unexpected heavy contamination occurs during the procedure.
But not routinely after the surgery ends.
No, and this is a really important point emphasized in the source. There is no evidence that giving further prophylactic antibiotic doses after the surgery is completed is of any value for preventing infection. In fact, continuing antibiotics unnecessarily after surgery is harmful because it only contributes to the development of antibiotic resistance and increases the risk of side effects like C. diff.
Okay, that's clear. The choice of antibiotic for prevention depends on the type of surgery then. You wouldn't use the same drug for brain surgery as for bowel surgery.
Exactly. It's tailored to the surgery type because different operations have different likely bacterial contaminants. A bowel operation is going to involve gut bacteria, whereas a clean skin procedure will mainly involve skin bacteria. Hospital guidelines and protocols usually standardize the choice based on the expected spectrum of organisms for that specific procedure, as well as considering the patient's allergies, of course.
And you mentioned special cases needing prophylaxis earlier, patients with implants.
Yes. Patients with certain conditions, like pre-existing heart valve disease or artificial implants such as vascular grafts or joint replacements, need antibiotic prophylaxis, even for procedures that might seem minor, but could potentially release bacteria into the bloodstream, causing a transient bacteremia.
Like dental work.
Exactly. Dental procedures, urological instrumentation, or any surgery where a hollow organ like the bowel is opened, even if it's not the primary site of surgery. The risk is that these circulating bacteria could travel and lodge onto the artificial surface or damaged heart valve, causing a catastrophic infection of the prosthesis or endocarditis.
That makes sense.
Yeah.
Now let's talk about when the body's defenses are already weakened, sort of setting the stage for infection even before the surgery. Reduced resistance.
Right. This is the state of reduced host resistance. It's caused by underlying conditions or treatments that impair the normal inflammatory response, which is the body's core defense mechanism against infection.
What kind of patient conditions do this?
Things like poor nutritional status again, both being significantly underweight and morbidly obese. Metabolic diseases like poorly controlled diabetes, chronic kidney failure causing uremia, severe liver disease causing jaundice, or widespread disseminated malignancy like cancer that is spread. Conditions like AIDS also severely compromise immunity.
And medical treatments can also do this, sometimes deliberately.
Unfortunately, yes. Medical interventions like radiotherapy and chemotherapy used to treat cancer are designed to kill dividing cells, and that includes immune cells. Immunosuppressant drugs, such as corticosteroids or methotrexate, used for autoimmune diseases or after transplants, also deliberately dampen the immune system. These are iatrogenic factors caused by medical treatment that weaken defenses, as you might see in figures 5.4 and 5.5.
The source also talks about gut failure and bacterial translocation. That sounds serious. What's the link there? How does a problem in the gut lead to systemic issues?
This is a critical concept, especially in critically ill or postoperative patients. When patients are very unwell, perhaps in shock, or their gut function is compromised, for example, if they aren't receiving adequate nutrition via the gut, enteral feeding, for prolonged periods, the normal balance of bacteria in the gut changes dramatically. Aerobic gram-negative bacteria, which are usually confined to the large bowel, can start to overgrow and colonize the upper parts of the digestive tract, like the stomach and small intestine, which are normally relatively sterile.
Okay, so the wrong bugs move into the wrong neighborhood.
Pretty much. And from there, these bacteria or components of their cell walls can actually cross the gut lining, which becomes more permeable or leaky when inflamed or poorly nourished, and enter the bloodstream or the lymphatic system. This process is called bacterial translocation. They often end up in the mesenteric lymph nodes first, as shown in figure 5.6.
And this translocation can trigger a dangerous body-wide response, like a domino effect.
Yes. The cell walls of gram-negative bacteria contain a substance called lipopolysaccharide, or LPS, also known as endotoxin. If these bacteria or significant amounts of their endotoxin enter the bloodstream, it triggers a massive, potentially harmful systemic inflammatory response. It essentially overstimulates immune cells like macrophages, causing them to release excessive amounts of pro-inflammatory cytokines like interleukin-6, IL-6, and tumor necrosis factor, TNF.
And this is a driver of SIRS.
It can be a major driver of systemic inflammatory response syndrome, or SIRS, yes.
So when resistance is low, generally, even bacteria that are usually harmless, just living on us, can become a problem.
Exactly. This is what we call opportunistic infection. Microorganisms that are normally present in or on the body without causing any issues, our commensal flora, can seize the opportunity presented by a weakened immune system or altered environment, like after antibiotics, to invade tissues and cause disease. Fungal infections, for example, particularly with Candida species, can become a significant problem in patients who have been on prolonged courses of broad-spectrum antibiotics, because the antibiotics have eliminated the bacteria that normally keep the fungi in check.
Let's pivot to how these infections actually show up after surgery. The source mentions hospital-acquired infections, or HAIs again here. What are the common types in surgical patients?
Right, HAIs are infections acquired as a result of healthcare intervention, or just being in the hospital. In surgery, the main types we worry about are respiratory infections, like hospital-acquired pneumonia, HAP, or ventilator-associated pneumonia, VAP, in patients needing breathing support. Urinary tract infections, UTIs, very commonly associated with urinary catheters. Bloodstream infections, often linked to indwelling intravenous lines or catheters. And of course, surgical site infections, SSIs themselves.
And SSIs are further classified into minor and major. What's the difference?
Yes, it's based on severity and impact. Minor SSIs might involve some redness or a small amount of discharge or pus, maybe needing a dressing change, but they don't typically cause significant systemic illness or delay the patient's recovery or discharge from hospital. You might see an example in figure 5.7. Major SSIs, on the other hand, involve a significant collection of pus requiring formal drainage. The patient is usually systemically unwell with fever, raised white blood cell count, maybe chills, and their hospital stay is definitely prolonged. Think figure 5.4 again, or summary box 5.6 criteria.
It's still surprising to me that many SSIs show up after the patient has gone home. How common is that?
It is surprising, but it's true. Studies suggest that up to 75%, maybe even more for some procedures, of SSIs present after hospital discharge. This really highlights the importance of educating patients about what signs and symptoms to look for, increasing redness, pain, swelling, discharge, fever, and having good systems for follow-up care, maybe via phone calls or clinic visits.
When do they typically appear?
Suppurative wound infections, the ones with pus, often develop around 7 to 10 days after surgery. Cellulitis, that spreading redness, can appear a bit earlier, sometimes around 3 to 4 days post-op.
Let's focus on localized infections first, abscesses. The classic collection of pus.
Right. Abscesses are localized collections of pus walled off within a tissue. They typically show the classic signs of inflammation first described thousands of years ago by Celsus: calor, heat, rubor, redness, dolor, pain, and tumor, swelling. We add a fifth sign, functio laesae, or loss of function of the affected part. They can form after surgery, trauma like a puncture wound, or even if bacteria travel through the bloodstream from somewhere else and seed in a tissue metastatic spread.
What's actually happening inside an abscess microscopically? What's a pus made of?
Pyogenic bacteria, often as Staphylococcus aureus, is a prime culprit, trigger an intense inflammatory response that causes tissue necrosis, tissue death, and separation, the formation of pus. Pus is essentially a thick fluid made up of dead and dying white blood cells, mostly neutrophils that came to fight the infection, liquefied dead tissue debris, living and dead bacteria, and bacterial toxins. The body tries to wall it off with an inflammatory membrane composed of fibrinous exudate, edema, and inflammatory cells, and later granulation tissue starts to form around it.
Can antibiotics sterilize it?
Sometimes, if antibiotics partially kill the bacteria, but don't completely clear the collection and the body can't drain it, it can form a hard, chronic inflammatory lump called an antibioma. It's like a partially sterilized, walled-off battlefield.
And the pain comes from pressure building up inside.
Exactly. The material inside an abscess is hyperosmolar, meaning it has a higher concentration of solutes than surrounding tissues, so it draws fluid into the collection by osmosis. This increases the volume and pressure inside the walled-off cavity, stretching the surrounding tissues and causing significant pain. Abscesses tend to follow the path of least resistance, often expanding and eventually pointing towards the skin surface or bursting into a body cavity. Wound abscesses typically form around 7-10 days after surgery.
How are abscesses treated? Is there a golden rule?
The absolute fundamental principle of managing an abscess, a cornerstone of surgery for centuries, is drainage. You need to release the pus. Pus evacua, where there is pus, evacuate it. Traditionally, this is done by making an incision over the pointing area and allowing the pus to drain out incision and drainage, or I&D. The cavity might need to be gently explored and cleaned out, maybe curetted, to break down any internal walls or loculi.
And what about closing the wound afterwards? And antibiotics?
If you leave the cavity open after drainage, packing it lightly perhaps, it heals slowly from the bottom up by secondary intention. Crucially, in these openly drained abscesses, you often don't need systemic antibiotics as well because the source of infection, the pus, has been removed. The drainage is the primary treatment.
There are times you might use antibiotics with drainage.
Yes, there are nuances. If you drain an abscess, perhaps through a smaller incision or with a catheter, and decide to close the skin over it, close drainage, you would typically give antibiotics to help clear the remaining bacteria. But you'd only do this if you were confident you had completely drained the collection and removed any foreign material that might be lurking inside.
The source gives some examples.
Yes, it compares a perianal abscess, which might sometimes be drained and closed with antibiotics if it's simple, versus a pilonidal abscess near the tailbone, which often involves infected hair follicles and has a higher recurrence risk, so it's usually best left open to heal after drainage. Small breast abscesses can often be successfully treated with just needle aspiration to remove the pus, combined with antibiotics, avoiding an incision altogether. This is outlined in Summary Box 5.7.
What about chronic or deep abscesses? Ones that don't heal easily or are hidden?
Abscesses that don't fully resolve or keep recurring can become chronic, sometimes forming a sinus, a blind tract opening onto the skin surface, or a fistula, an abnormal tract connecting two epithelial surfaces, like between the bowel and the skin. Specific organisms like Mycobacterium, related to TB, or Actinomyces, a filamentous bacterium, are sometimes involved in these stubborn chronic cases. Deep abscesses, like those hidden inside the abdomen, perhaps near a surgical joint, perianastomotic, or after an anastomotic leak, are much harder to diagnose clinically. Imaging techniques, ultrasound, CT scans, MRI, sometimes even isotope scans are essential for locating them, like in Figure 5.8. And often, these deep collections can be drained less invasively using imaging guidance to place a needle or drainage catheter accurately, avoiding the need for a major repeat operation.
Okay, moving from localized pus collections to spreading infections like cellulitis and lymphangitis, how are they different?
Cellulitis is a very different beast. It's a widespread, non-suppurative inflammation, meaning no significant pus collection that spreads rapidly through the skin and subcutaneous tissues. It still has the cardinal signs: redness, warmth, pain, and swelling. But the edges are usually poorly defined. It's not localized to one spot. It's typically caused by fast-spreading organisms like beta-hemolytic streptococci, or sometimes Staphylococcus, or even Clostridium perfringens in some cases.
And it can be dangerous because it spreads so quickly through the tissue planes.
Exactly. These organisms often release enzymes that actively break down the connective tissue matrix, allowing them to move rapidly. This can lead to widespread tissue destruction, potentially even gangrene or deep ulceration if not treated promptly. Even without a large collection of pus, the patient can get very sick systemically. They often develop chills, high fever, and rigors. These are signs of toxemia and a significant systemic inflammatory response. This is triggered by bacterial toxins circulating in the bloodstream and stimulating cytokine release, even if bacteria themselves aren't yet detectable in blood cultures. The systemic response can be quite profound.
And lymphangitis often goes along with cellulitis.
Yes, it's part of the same spreading inflammatory process. You often see painful red streaks tracking up the limb along the course of the lymphatic vessels that are draining the infected area. The regional lymph nodes, maybe in the armpit or groin depending on the location, become enlarged, swollen, and tender as they try to filter the infection. This is covered in Summary Box 5.8.
There are some specific, particularly nasty and notorious local wound infections we need to talk about. First, gas gangrene. That sounds terrifying just from the name.
It is. Gas gangrene is a rapidly progressing, life-threatening infection, classically caused by Clostridium perfringens. Remember, these are anaerobic, gram-positive, spore-bearing bacilli found in soil and feces.
Who is most vulnerable to this?
Patients with weakened immune systems, diabetes, or underlying malignant disease are at higher risk. But the key factor is the presence of necrotic, dead, or devitalized tissue, or foreign material in a wound, especially if there's significant contamination. This creates the low-oxygen anaerobic environment these bacteria absolutely love. Deep, soiled military wounds with extensive tissue damage are a classic example, but it can also occur after civilian trauma or even surgery, particularly involving ischemic limbs.
What are the telltale signs? How would you recognize it?
The onset is often sudden and dramatic. Severe local pain is a key early feature, often described as being out of proportion to the apparent state of the wound. Then you might notice crepitus, a crackling or popping sensation when you press on the skin, caused by the gas the bacteria produce as they ferment tissue carbohydrates. This gas might also be visible on an X-ray. The wound itself might have a thin, brownish, often sweet-smelling exudated breast. A gram stain of this fluid will show the characteristic large, gram-positive rods.
And it progresses rapidly.
Very rapidly. This is followed by marked edema, swelling, skin discoloration, blistering, and spreading gangrene as the bacteria release powerful tissue-destroying enzymes like collagenase, hyaluronidase, proteases, and importantly, alpha-toxin, which causes massive tissue necrosis and hemolysis.
And it's systemically dangerous very quickly. It's not just a local problem.
Absolutely. Patients can rapidly develop systemic complications like circulatory collapse, shock, and multiple organ failure if prompt action isn't taken. The toxins produced are potent. This is why antibiotic prophylaxis is considered essential in high-risk surgeries, like lower limb amputations for peripheral vascular disease, PVD, where there's often pre-existing ulceration or gangrene.
Once established, what's the treatment?
It has to be immediate and aggressive. Treatment involves large doses of intravenous penicillin or alternative antibiotics if allergic. But crucially, the cornerstone is urgent and extensive surgical debridement, removing all the affected dead muscle and tissue. This often requires radical excision, sometimes even amputation. Hyperbaric oxygen therapy is sometimes used as an adjunct, but surgery is primary. Summary Box 5.9 covers this.
Next, another clostridial infection, less common now thanks to vaccination, but still feared, tetanus.
Tetanus, yes. Caused by Clostridium tetani, another anaerobic spore-forming gram-positive rod found in soil and animal manure, particularly horse manure. The infection starts when spores are implanted into tissues, often through a puncture wound, even a seemingly minor one or a contaminated wound.
And the danger here isn't tissue destruction, but a potent toxin.
Exactly. The bacteria themselves don't spread much, but they produce an incredibly powerful neurotoxin called tetanospasmin. This exotoxin travels along nerves to the central nervous system.
What does the toxin do there?
It interferes with the release of inhibitory neurotransmitters, leading to uncontrolled nerve firing and severe muscle spasms. It typically starts with stiffness in the jaw, lockjaw or trismus, because the facial nerves are shorter, then progresses to spasms of the facial muscles, rectus sardonicus, a characteristic grimace, neck, back, oppositonus, extreme arching, and limbs. It can cause laryngospasm, respiratory muscle paralysis, leading to respiratory arrest and death.
Prevention is the key here, then.
Prevention through tetanus toxoid vaccination and appropriate boosters is by far the best approach and highly effective. That's why wound management always includes assessing tetanus immunization status.
But if established infection occurs...
Treatment for established tetanus involves minor wound debridement to remove any remaining source of bacteria, antibiotics like benzylpenicillin to kill the C. tetani bacteria, though this doesn't neutralize toxin already released, muscle relaxants, and often intensive care support, including mechanical ventilation in severe forms. Even with modern ICU care, mortality remains significant.
Finally, one of the most terrifying surgical emergences, necrotizing fasciitis, sometimes called synergistic spreading gangrene.
This is thankfully rare, but it is an extremely serious, rapidly progressive infection. It spreads aggressively along the deep fascial planes, the tough fibrous tissue layers that cover muscles, often sparing the overlying skin initially, which can make diagnosis tricky in the early stages.
And it's often caused by multiple bacteria working together, hence the synergistic name.
Yes, that's typically the case. It's usually a mixed pattern of organisms acting in synergy. You often find a combination of aerobic bacteria, like coliform, Staphylococcus, and anaerobic bacteria, like anaerobic Streptococcus, Streptococcus, bacteroids. The theory is that the aerobes consume oxygen and destroy tissue, create the perfect low oxygen environment for the anaerobes to thrive, and together they produce enzymes that cause massive, rapid tissue destruction.
What clinical signs should raise a very high suspicion for this? It sounds like early recognition is crucial.
Absolutely crucial. Key signs include severe wound pain, often described as disproportionate to the visible skin changes, rapidly spreading signs of inflammation, redness, swelling, heat, sometimes with overlying skin blistering or turning a dusky purple color. Crepitus, gas under the skin, can sometimes be present, and there might be a foul odor.
And if untreated, the progression is grim.
Untreated, it leads to widespread local gangrene of skin, fat, and fascia, and rapidly progresses to systemic toxicity, septic shock, and multi-system organ failure. Specific name types include Mullany's gangrene, which typically affects the abdominal wall after surgery, and Fournier's gangrene, a particularly aggressive form affecting the scrotum and perineum, shown in figure 5.1.
And it's particularly common in people with weakened immune systems, like gas gangrene.
Almost always, yes. Diabetes is a major risk factor, but it can affect anyone who is immunocompromised. It may follow even relatively minor trauma or surgery, especially if the wound was contaminated.
Given how quickly it spreads into the skin, and the skin might look deceptively okay initially, how is it diagnosed definitively?
That's the challenge. The subdermal spread is often far more extensive than the surface appearance suggests. A key diagnostic tool described in the source is the finger test. Under local anesthesia, you make a small 2-centimeter incision down to the deep fascia in the suspicious area. If you encounter a lack of normal bleeding, see thin, grayish dishwater fluid instead of pus, and find that you can easily dissect the fascial plane from the underlying muscle using your finger with very little resistance, that's highly suggestive of necrotizing fasciitis.
Are there other tests?
A tissue biopsy taken from the affected fascia for frozen section examination can also be helpful, showing characteristic features like obliterative vasculitis, inflammation, and necrosis. However, if the clinical suspicion is high based on progressive findings or the finger test is positive, you shouldn't delay. Immediate operative treatment is required.
And the treatment is as radical and urgent as the infection sounds.
Absolutely immediate and radical surgery is the cornerstone. The primary treatment is extensive surgical debridement, wide excision of all the necrotic fascia, fat, and overlying skin until you reach healthy bleeding tissue. This often involves laying the wound wide open and may require multiple return trips to the operating room for further debridement.
And antibiotics. Support.
Yes, this is combined with aggressive, broad-spectrum intravenous antibiotic therapy covering aerobic and anaerobic bacteria. Patients also need intensive circulatory support, often in an ICU setting, to manage shock and organ dysfunction. Later on, extensive skin grafting is usually required to close the large defects left by the debridement. It's a devastating infection requiring maximal effort.
So we've covered local infections, from contained abscesses to rapidly spreading gangrene. What happens when infection overwhelms the body's defenses and goes systemic? Spills into the bloodstream.
That leads us to the concepts of bacteraemia and the systemic inflammatory response syndrome, SARS-PADS. Bacteraemia simply means the presence of bacteria in the bloodstream.
Is it common after surgery?
It's unusual after superficial SSIs that drain externally, but it's much more common with deep space SSIs, like an intra-abdominal abscess following an anastomotic breakdown. It can also occur transiently after procedures that involve manipulating instruments through infected tissues, like infected bile during gallbladder surgery or infected urine during urological procedures. Indwelling intravenous catheters are another common source if they become colonized.
And it's a major risk if you have an artificial implant, as we discussed.
Critically important. If bacteria enter the bloodstream, even transiently, They can travel through the circulation and stick to artificial surfaces like heart valves, vascular grafts, or joint replacements. This hematogenous spread can lead to a devastating infection of the prosthesis itself, often requiring its removal.
What kind of bacteria usually cause bacteremia?
Common causes include aerobic gram-negative bacilli, like E. coli from a UTI or gut source, Staphylococcus aureus, often from skin or line infections, and sometimes fungi, particularly in immunocompromised patients or those on long-term antibiotics. Bacteraemia, especially persistent or involving virulent organisms, can directly lead to systemic organ failure. Summary box 5.1 touches on this.
The source then defines systemic inflammatory response syndrome, or SIRS. How is that different from just having bacteria in your blood? They sound related.
They are definitely related but distinct. That's a key distinction to grasp. SIRS is the body's overwhelming systemic inflammatory response to a severe insult. It's often triggered by severe infection, which we call sepsis when infection causes organ dysfunction, often via SIRS, particularly by the lipopolysaccharide, LPS, endotoxin, released from the cell walls of gram-negative bacilli like E. coli, or components from other bacteria or fungi. This stimulates a massive release of inflammatory chemicals, cytokines, from immune cells like macrophages.
But it's not only caused by infection.
Correct. And importantly, the source notes that SIRS can also be triggered by other severe non-infectious insults like major trauma, extensive burns, or severe pancreatitis. So, while sepsis causes SIRS as part of its pathophysiology, having SIRS doesn't automatically mean you have an infection, although the criteria for SIRS are used as part of the diagnostic process for sepsis.
And what are those clinical criteria for SIRS? How do you recognize it?
The source refers to the classic consensus criteria listed in Table 5.1. You need to meet at least two of the following four signs. First, a change in body temperature, either high, fever 38 degrees, or low, hypothermia 36 degrees C. Second, an increased heart rate, tachycardia 90 BPM. Third, an increased breathing rate, tachypnoea 20 breaths min, or low level of carbon dioxide in the blood. And fourth, a change in the white blood cell count, either very high, leukocytosis 12,000 millimeters, or very low, leukopenia 4,000 millimeters, or having a high percentage of immature neutrophils.
How does this uncontrolled inflammation actually lead to organs failing? It seems counterintuitive inflammation is meant to be protective.
Normally, it is protective. The inflammatory response, mediated by pro-inflammatory cytokines like interleukin-1, IL-1, and TNF-alpha, is designed to recruit immune cells, like neutrophils, to the site of infection or injury. These neutrophils adhere to blood vessel walls, migrate into tissues, release chemicals in a respiratory burst to kill bacteria, and also stimulate coagulation, complement, and fibrinolytic pathways, all usually beneficial for containing the problem.
But in SIRS, it goes haywire.
Exactly. When this inflammatory response becomes excessive and uncontrolled, it's SIRS. High circulating levels of these cytokines and large numbers of activated neutrophils cause the systemic signs we just mentioned, fever, tachycardia, etc. But critically, these activated neutrophils can also start to damage the delicate lining of blood vessels, the vascular endothelium, not just at the site of infection, but in remote organs throughout the body.
Causing collateral damage.
Precisely. This endothelial damage leads to increased vascular permeability, leaky blood vessels. Fluid leaks out, proteins leak out, and immune cells cause further collateral damage within these distant organs. This progressive injury leads to organ dysfunction, what we call multiple organ dysfunction syndrome, or MODS.
And MODS can escalate further.
Yes. Severe MODS progresses to multiple system organ failure, or MLOF. This is when multiple vital organs, lungs, ARDS, heart, kidneys, liver, gut, coagulation system start to fail simultaneously, often accompanied by refractory circulatory failure or shock. It becomes a devastating vicious cycle. As more organs fail, the body's overall resistance and ability to fight the underlying insult diminishes further, increasing the likelihood of death despite maximal support in the intensive care unit, ICU. Summary box 5.11 provides definitions for these terms.
This sounds like a major focus of critical care medicine. You mentioned initiatives like the Surviving Sepsis Campaign earlier.
Yes. Because sepsis and its progression to SIRS, MON-IS, and MSOF are major causes of death in hospitals worldwide, international collaborations like the Surviving Sepsis Campaign, involving groups like the European Society of Intensive Care Medicine and the Society of Critical Care Medicine, were launched specifically to improve outcomes and reduce mortality. They developed evidence-based guidelines and treatment bundles.
The sepsis bundle.
Exactly. The sepsis bundle, specifically the resuscitation bundle, outlines a set of key evidence-based actions and objectives that should be initiated and ideally completed within the first few hours, originally 6 hours, now often aiming for even faster, for patients presenting with severe sepsis or septic shock.
And the Sepsis 6 used in the UK is a specific, actionable version of that bundle.
That's right. The Sepsis 6, developed by the UK Sepsis Trust, is a simplified, practical therapy bundle designed for rapid implementation by frontline staff, particularly in the emergency department or on the ward, often within the first hour. It has a very memorable structure. Give 3, take 3.
Okay, what are the 6 things?
You give the patient 3 crucial interventions: high-flow oxygen to maintain saturation, broad-spectrum intravenous antibiotics, and intravenous fluids, often a rapid bolus. And you take 3 important diagnostic samples measurements: blood cultures, ideally before antibiotics, measure serum lactate, a key marker of tissue hypoperfusion and illness severity, and monitor hourly urine output accurately, reflecting kidney perfusion. Implementing these 6 steps quickly and reliably has been shown to significantly improve survival rates from sepsis.
Beyond bacteria, which we focused heavily on, the source also touches on viral infections that are particularly relevant to surgery, especially regarding the risk of transmission between patients and healthcare staff.
Absolutely. Bloodborne viruses are a significant occupational hazard in surgery. Hepatitis B and hepatitis C are prime examples. There's a clear risk of transmission via needle stick injuries or cuts with sharp instruments, potentially going both ways from patient to surgeon or vice versa, although patient to surgeon is more common.
And hepatitis B can be carried silently.
Yes, many people infected with hepatitis B become chronic, asymptomatic carriers, meaning they can transmit the virus without knowing they have it. This is why vaccination against hepatitis B is so important for healthcare workers, especially surgeons, who should know their immune status and be vaccinated. Hepatitis C also carries a risk of chronic infection, which can lead to severe liver damage over time. While potentially curable treatments involving drugs like interferon alpha and ribavirin exist, prevention of exposure is key. Any exposure incident requires immediate reporting and expert advice from occupational health, usually involving antibody testing for both source and recipient.
Human immunodeficiency virus, or HIV, is another major concern for transmission.
HIV, the type 1 retrovirus that causes AIDS, is another bloodborne pathogen. It's transmitted primarily through sexual contact, sharing contaminated needles among IV drug users, and exposure to infected blood or blood products. In the surgical context, the main risk is again from percutaneous exposure, needle stick injuries, or cuts.
What are the stages of HIV infection?
Initial HIV infection can cause a flu-like illness a few weeks after exposure. This seroconversion phase, when the body first develops antibodies, is actually a period of very high viral load and high transmission risk. Modern treatment with highly active antiretroviral therapy, or HAART, has revolutionized HIV management. If started early, HAART can very effectively suppress viral replication, allowing people to live long, healthy lives. However, it doesn't completely clear the virus, and treated patients can still potentially transmit HIV, although the risk is much lower if their viral load is undetectable.
And untreated HIV progresses to AIDS.
Yes. Without treatment, a significant percentage of people, maybe 25-35% within about 2 years, according to the source, progress to acquired immunodeficiency syndrome, or AIDS. This is characterized by severe immune deficiency, leaving the person highly vulnerable to opportunistic infections caused by microbes that don't usually harm healthy people, like pneumocystis jirovecii pneumonia, certain types of tuberculosis, TB, cytomegalovirus, CMV infections, and also certain types of cancers, particularly Kaposi's sarcoma and lymphomas.
To protect everyone, patients and staff, universal precautions are critical when dealing with blood and body fluids.
Absolutely essential. Universal precautions are a standard set of infection control practices designed to prevent the transmission of bloodborne pathogens in healthcare settings. The core principle is to treat all blood and potentially infectious body fluids as if they are infectious, regardless of the patient's known status.
What does that mean specifically in the operating room?
In surgery, where exposure to blood and aerosols is a significant risk, especially with power tools or splashing, these precautions include wearing appropriate personal protective equipment, PPE, full face masks or goggles visors to protect mucous membranes, waterproof gowns and drapes, sometimes waterproof boots. Double gloving is often standard practice. It also involves minimizing the number of personnel and unnecessary movement in the theater, handling sharp instruments, sharps, with extreme care, using safe techniques like neutral zones, and employing meticulous surgical technique to minimize bleeding and splashing in the first place. It's about respecting the potential risk in every case.
What happens if an exposure incident does occur, like a needle stick injury? What's the procedure?
Needle stick injuries are unfortunately common in surgery, particularly involving the non-dominant index finger, And hollow bore needles used for injections or drawing blood carry a higher risk of transmitting viruses than solid needles like suture needles. If an injury occurs, the first step is to encourage bleeding from the wound, wash the injured part thoroughly with soap and water, and then immediately report the incident according to local hospital policy.
And then what?
Local protocols will then guide the next steps, which usually involve assessing the risk based on the source patient, if known, and the nature of the exposure. This will determine if post-exposure prophylaxis, PEP, with antiretroviral drugs is recommended for HIV, or if specific follow-up for hepatitis B or C is needed. Occupational health services provide essential confidential advice, testing, counseling, and long-term support. In some cases, depending on the circumstances or personal risk tolerance, it might lead to discussions about considering a non-operative specialty.
The source material, reflecting recent history, also includes specific information on the COVID-19 pandemic.
Yes, the COVID-19 pandemic caused by the SARS-CoV-2 virus. It was declared a global pandemic by the WHO in March 2020, and, as the source notes with statistics from August 2021, had a profound impact on healthcare worldwide, including surgical services.
How did it affect surgery specifically in the short term?
The immediate impact was massive disruption. Most elective, non-urgent surgery was postponed significantly, sometimes for many months, to free up hospital beds, especially ICU beds, conserve PPE, and reduce the risk of viral transmission within hospitals. Emergency and time-sensitive surgery, like for cancer or trauma, generally continued, but with enhanced precautions, including rigorous use of PPE by surgical teams, especially during airway procedures.
What were the specific concerns for surgical patients who contracted COVID-19 around the time of their operation?
COVID-19, as we know, is primarily a respiratory illness but can affect multiple organ systems. While many infections were mild, severe outcomes included acute respiratory distress syndrome, ARDS, a dangerous cytokine storm, an excessive inflammatory response, multi-organ failure, septic shock, and an increased tendency for blood clotting, hypercoagulability. Studies quickly showed that patients undergoing surgery who were also COVID positive, especially asymptomatic, face significantly higher risks of serious postoperative complications, including pneumonia, ARDS, multi-organ failure, septic shock, and death, compared to COVID-negative patients having similar surgery.
So specific control measures were put in place for surgery.
Yes. To mitigate these risks, many healthcare systems implemented control measures for patients undergoing planned elective surgery. These often included mandatory preoperative self-isolation or cocooning for 10-14 days before admission, and routine preoperative swab testing for SARS-CoV-2, typically 2-3 days before the scheduled surgery, to identify and postpone infected patients.
And treatments.
At the time the source text was likely finalized, there was no definitive pharmacological cure, although supportive care was paramount, and some evidence was emerging for agents like dexamethasone, a steroid, reducing mortality in severe cases, while others like hydroxychloroquine had been largely discounted. Vaccines became available in late 2020, which dramatically changed the landscape moving forward.
That was a major disruption and a stark reminder of how new infectious threats can emerge and challenge surgical practice. Let's shift now fully to the proactive side, preventing surgical infection in the first place. What are the key best practices outlined?
Prevention really starts well before the patient even reaches the operating room. Minimizing the preoperative hospital stay is beneficial whenever possible. The less time a patient spends in the hospital before surgery, the lower their risk of becoming colonized with resistant hospital bacteria like MRSA or resistant coagulus-negative Staphylococcus from the hospital environment itself.
And hand hygiene is paramount.
Absolutely paramount. It remains the single most important measure for preventing the spread of infection by healthcare workers. Washing hands thoroughly with soap and water or using alcohol-based hand gels containing 70% alcohol before and after every patient contact is crucial. Public health initiatives like the Clean Your Hands campaign have demonstrably reduced hospital infection rates by improving compliance.
But gels don't kill everything.
Correct. It's vital to remember that alcohol-based gels do not reliably destroy bacterial spores, most importantly Clostridium difficile spores. So for C. diff, physical washing with soap and water is necessary to remove the spores.
And staff with active infections should stay away from theater.
Definitely. Staff with infected skin lesions, boils, or other potentially transmissible infections should be excluded from the operating theater environment. Similarly, patients scheduled for elective surgery, especially if a prosthetic implant is planned, should ideally have any active infections elsewhere in their body treated and resolved before proceeding.
What about things like antiseptic baths or shaving?
Preoperative antiseptic baths, using agents like chlorhexidine, are quite popular in some places, but the source notes that the evidence supporting their routine use to significantly reduce SSI rates is actually limited. Regarding hair removal, if it's necessary at the surgical site, the timing is important. Shaving should ideally be done with clippers, not razors, which cause microabrasions, in the operating theater immediately before the skin preparation and incision. Shaving like before significantly increases the risk of minor skin injury, which can then become colonized with bacteria overnight, effectively doubling the SSI risk in clean surgeries.
Okay, now during the operation itself, intraoperatively, what are the key practices in theater for prevention? Figure 5.1 gives a visual summary.
Intraoperative technique and discipline are absolutely critical. It starts with the surgical team scrub, using effective antiseptic soaps like chlorhexidine or povidone iodine for a timed scrub or rub. Then the patient's skin at the operative site is prepared meticulously with a concentrated alcohol-based antiseptic solution. A single thorough application can achieve a greater than 95% reduction in resident skin bacteria. However, care must be taken to avoid pooling of flammable alcohol solutions, especially near drapes, due to the fire risk with electrocautery, diathermy.
And maintaining discipline in the OR.
Yes, maintaining strict discipline within the operating room environment is also key. This includes minimizing the number of people present and restricting unnecessary movement and conversation. Rigorous surveillance of instrument sterilization processes, adherence to aseptic technique throughout the procedure by everyone involved, and maintaining the quality of theater ventilation are all important. Specialized systems like laminar airflow ventilation are often used for high-risk procedures like joint replacement surgery to further reduce airborne contamination.
And the surgeon's skill plays a role too, even if it's hard to measure.
Undoubtedly.
Yep.
Although difficult to audit objectively, the skill of the operator in handling tissues gently, avoiding unnecessary tissue damage or crushing, meticulously controlling bleeding to prevent hematomas, and obliterating dead spaces where fluid could collect, all contribute significantly to creating a healthier wound environment that's less susceptible to infection.
Are there common practices sometimes used in theater that don't actually seem to help prevent infections, according to the evidence?
Yes. Interestingly, the source points this out. Despite their common use, there is currently no strong evidence showing that routinely placing surgical drains within the wound itself, as opposed to draining a specific collection, applying adhesive plastic incision drapes over the prepared skin before incision, or using plastic wound guards or protectors during surgery actually helps reduce surgical site infection rates.
But conversely, some seemingly simple interventions do have strong evidence supporting them for SSI prevention.
Correct. Two key evidence-based strategies highlighted are, first, actively avoiding perioperative hypothermia. That is, keeping the patient warm, using measures like forced air warming blankets during and immediately after surgery. And second, using supplemental oxygen administration during the recovery period immediately after surgery. Both of these interventions have been shown by high-level evidence from randomized controlled trials to significantly reduce the rate of SSIs.
Let's revisit prophylactic antibiotics, specifically from the prevention perspective. When is it generally considered necessary to use them?
Prophylactic antibiotics, meaning antibiotics given before potential contamination occurs, are used when the expected risk of bacterial contamination during the surgical procedure is considered significant enough to warrant intervention, or when the consequences of an infection, even if rare, would be catastrophic.
How is that risk estimated? The source mentioned a classification.
Yes. The risk is often estimated using a widely accepted surgical wound contamination classification system, like the one originally developed by the U.S. National Research Council, NRC, described in Table 5.2. It helps stratify the inherent risk of the procedure itself.
And how does that classification work? What are the categories?
Surgeries are broadly classified into 4 categories based on the likelihood and type of bacterial exposure during the operation.
These are procedures where no infection is present, there's no inflammation, no break in aseptic technique, and no hollow viscus, like the gut, respiratory, or urinary tract, is opened. Examples include hernia repair without mesh, breast biopsy, or thyroidectomy. The expected infection risk is very low, typically 2%.
Okay, next.
Clean contaminated wounds. These involve opening a hollow viscus, like the respiratory, gastrointestinal, or genitourinary tract, but under controlled conditions with minimal spillage or contamination. Examples include elective bowel resection with primary anastomosis or hysterectomy. The infection risk is higher, maybe 5–10%.
And contaminated.
Contaminated wounds. These include operations with major breaks in sterile technique, gross spillage from the GI tract, or incisions into acutely inflamed but non-purulent tissues. Examples include surgery for fresh traumatic wounds, bile spillage during gallbladder surgery, or surgery for non-perforated appendicitis or diverticulitis. The infection risk here is significantly higher, perhaps 15–20%.
And finally, the highest risk.
Dirty or infected wounds. These involve operating on tissue with existing infection, like incising an abscess, or procedures where perforation of a viscus, like a perforated appendix or bowel, or established infection is encountered. Traumatic wounds with retained dead tissue or foreign bodies also fall here. The infection risk is very high, often 30–40%.
So antibiotic prophylaxis is more valuable as the contamination risk increases or if the stakes are very high.
Precisely. The value of routine prophylaxis is generally considered low in non-prosthetic clean surgery because the baseline infection rate is already very low, and the potential downsides, cost, side effects, resistance, may outweigh the small benefit. However, prophylaxis is essential in clean surgery when a prosthetic implant, like a joint replacement, heart valve, or vascular graft, is being inserted, because even a low infection rate is unacceptable due to the catastrophic consequences of prosthetic infection.
And for the other categories.
There's undisputed evidence showing the effectiveness of prophylactic antibiotics in significantly reducing SSI rates in clean contaminated and contaminated operations. For dirty infected wounds, giving antibiotics is less about prophylaxis, preventing infection, and more about early treatment of an infection that is essentially already present or considered inevitable. In these cases, a longer therapeutic course of antibiotics, perhaps for 5 days, is usually justified, starting perioperatively.
And the timing, again, is critical for prophylaxis.
Absolutely paramount. It must be given so that adequate bactericidal concentrations are present in the tissues during that decisive period when contamination might occur, essentially, from the time of incision until wound closure. As we said, IV administration at induction of anesthesia is generally optimal. Repeat doses only for very long procedures, significant blood loss, or unexpected heavy contamination. And, to reiterate the crucial point, no evidence supports routine postoperative doses purely for prophylaxis. This practice only encourages resistance.
Choice of antibiotic follows local guidelines, tailored to the expected bugs.
Exactly. The choice should be based on the microorganisms most likely to cause infection for that specific type and site of surgery, considering local resistance patterns and patient allergies. Hospital antibiotic policies usually provide clear guidance on recommended regimens for common procedures.
And special patient groups need protection, even for seemingly unrelated procedures.
Yes, patients with conditions that make them highly susceptible to seeding of infection, like those with prosthetic heart valves, previous endocarditis, or major prosthetic implants, vascular orthopedic, need appropriate antibiotic prophylaxis before procedures known to cause transient bacteraemia, even things like dental extractions, cystoscopy, or colonoscopy to prevent disastrous colonization of their implant. Summary Box 5.12 covers prophylaxis principles.
All right, despite all best efforts at prevention, infections still happen. What about managing established postoperative infections? How does the source guide us there?
Well, first, identifying the source is important if possible. The vast majority of established SSIs still originate from the patient's own endogenous flora that gained access during surgery. However, if you suddenly see a cluster or outbreak of infections on a ward, particularly involving the same bacterial species with the same antibiotic sensitivity pattern, you have to strongly suspect an exogenous source, perhaps a contaminated instrument, an environmental reservoir, or transmission via staph due to a breakdown in infection control standards like hand hygiene.
And that requires investigation.
Absolutely. An outbreak situation requires prompt investigation, often involving swabbing patients, staff, and the environment, reviewing procedures, and potentially even temporary ward closure for deep cleaning and reinforcement of infection control practices.
And we know many infections appear after discharge.
Yes, that point bears repeating. Up to 75% are detected after the patient leaves the hospital. This means effective management relies on good patient education about warning signs and accessible pathways for assessment and treatment if problems arise. Suppurative infections typically show up 7–10 days post-op, while cellulitis might be earlier, 3–4 days.
When are antibiotics definitely needed for an established infection? Is it always?
Not necessarily for very minor infections. However, antibiotics are definitely required for major SSIs, those causing systemic signs of infection, fever, tachycardia, high white cell count, infections involving rapidly spreading inflammation like cellulitis, or any situation where there's suspicion of deeper infection or bacteraemia.
And how is the antibiotic choice made? Is it just guesswork?
Initially, the choice is often empirical. Based on the type of surgery, the likely source, for e.g., skin versus gut, and local knowledge of common bacteria and resistance patterns, you make an educated guess the best choice likely to cover the probable pathogens. However, the ideal approach is always to obtain a specimen for microbiological culture and sensitivity testing before starting antibiotics, whenever feasible.
But you don't wait for the results if the patient is sick.
No, absolutely not. It typically takes 2-3 days to get sensitivity results back, as shown in figures 5.3, 5.15, 5.15, illustrating culture plates and sensitivity testing. You shouldn't withhold antibiotics if they are clinically indicated just to wait for lab results. You start empirical treatment, but the culture results then allow you to confirm if your initial choice was appropriate or if you need to adjust the antibiotics to target the specific organism found and its sensitivities.
Is changing antibiotics common once results are back?
Interestingly, the source notes that changing antibiotics is generally unusual if the initial empirical choice was sensible and the patient is showing signs of clinical improvement. Unnecessary switching of antibiotics is discouraged as it can promote further resistance development and also increases the risk of complications like antibiotic-associated diarrhea or C. diff enteritis. You typically only change if the patient isn't responding or the bacteria turns out to be resistant to your initial choice.
But antibiotics alone often aren't enough, especially if there's pus, right? You keep coming back to drainage.
Absolutely. Antibiotics alone are rarely sufficient to cure an established wound infection if there's a significant collection of pus or infected fluid under tension. Surgical drainage remains a fundamental principle. If an infected wound is clearly bulging, fluctuant, or discharging pus, any sutures or clips in that area need to be removed to allow open drainage. Sometimes the wound needs to be gently explored or curetted to break down loculi and ensure adequate drainage.
And what about the strategy for closing the wound itself after infection?
For heavily contaminated wounds or incisions that were deliberately made through an infected area, like draining an abscess, it's often best practice to leave the wound open initially. Figures 5.1c, 5.17 show examples. This allows for free drainage and cleaning. Once the infection has resolved and healthy granulation tissue has formed, you can then consider closing the wound, either by delayed primary closure, suturing the edges together after a few days, or secondary closure, allowing it to granulate significantly first. Some heavily infected wounds might even be managed entirely by secondary intention, allowing them to heal slowly from the base up, figure 5.1t, although this can result in significant scarring and may eventually require plastic surgical reconstruction, summary box 5.13.
Taking good specimens for culture is obviously important for guiding treatment if needed. Any tips on that?
Yes, getting a good quality specimen is crucial for the microbiology lab. Always try to take a sample of actual pus or infected tissue before starting antibiotics, if at all possible. Send it fresh to the lab. Swabs are less ideal than fluid or tissue, but if used, they should be placed in appropriate transport medium to keep bacteria viable. A larger volume of pus is always better than a scanty swab, and provide the microbiologist with relevant clinical information, patient details, site of infection, type of surgery, current antibiotics. This helps them interpret the results correctly.
What if you suspect bacteraemia?
If bacteraemia is suspected, but initial blood cultures are negative, it's often necessary to repeat the blood cultures, perhaps when the patient has a fever spike, and requesting an immediate gram stain on any positive bottles can provide very rapid, valuable preliminary information.
And what about using topical antiseptics directly on an infected wound? Does that help?
Topical antiseptic solutions or creams can sometimes be used for a short period on heavily contaminated or superficially infected wounds to help reduce the surface bacterial load and clear slough. However, it's important to use them judiciously. The source cautions that prolonged use can actually inhibit the ingrowth of new epithelial cells and impair the overall wound healing process. They can be toxic to healthy granulation tissue.
Okay, let's get into the details of the antimicrobial treatment itself. The source gives us an overview of fundamental principles and specific types of antibiotics commonly used in surgery. What's the absolute main principle?
The fundamental principle, worth stating again because it's so important, is that antibiotics do not replace the need for surgical drainage of established infection, especially abscesses. Summary box 5.14. Drainage comes first where applicable.
And antibiotics should only be used when genuinely indicated.
Yes. Only infections that are clearly spreading locally, like cellulitis, or those showing signs of systemic involvement, fever, raised white count, positive blood cultures, generally justify the use of systemic antibiotics. Treating simple, localized, well-drained infections with antibiotics is often unnecessary and just contributes to resistance.
The goal is always to know the enemy.
Whenever possible, yes. The ideal is always to determine the causative organism and its antibiotic sensitivity profile through culture to allow for targeted therapy.
What are the different strategic approaches to choosing antibiotics when you do need them?
There are a few main approaches. You can use a narrow-spectrum antibiotic if you have a known infection caused by a specific organism with predictable sensitivity. For instance, if you know you're dealing with MRSA, which is usually sensitive to glycopeptides, you wouldn't use flucloxacillin, which it's resistant to, but would use something like vancomycin or teicoplanin. More commonly, especially in emergency surgery or serious infections where the organism isn't yet known, or where you suspect a mixture of bacteria acting in synergy, like after a perforated bowel, you'll use broad-spectrum antibiotics or combinations. The aim here is to cover all the likely pathogens, gram-positives, gram-negatives, and anaerobes right from the start.
Can you give examples of those broad combinations used in serious mixed infections?
Sure, examples might include using a single agent with very broad aerobic coverage, like teicoplanin for gram-positives plus a carbapenem like meropenem for gram-negatives, potentially combined with metronidazole to ensure excellent anaerobic cover. Or sometimes a triple therapy approach is used, maybe combining something like amoxicillin or ampicillin plus an aminoglycoside like gentamicin for gram-negatives plus metronidazole for anaerobes. The exact choice depends heavily on the clinical scenario, local resistance patterns, and is often guided by specialist microbiology advice.
What if the patient isn't getting better on the chosen antibiotics after a few days?
If there's a poor clinical response after, say, 3-4 days of seemingly appropriate antibiotic therapy, you have to urgently reevaluate. Review the culture and sensitivity results when they become available. Actively investigate for potential complications, particularly an undrained collection of pus, abscess, which might require imaging like ultrasound or CT scan to find, or perhaps development of a resistant secondary infection.
And what about dealing with resistant bacteria that seem to become resident in certain hospital units, like resistant Pseudomonas?
That's a real challenge. In specialized units like ICUs or burns units that struggle with endemic colonization or infection by particularly resistant opportunistic pathogens, such as multi-drug resistant Pseudomonas or Klebsiella species, specific strategies might be needed. The source mentions that sometimes rotating the classes of antibiotics used empirically in that unit over time might be necessary as part of an antibiotic stewardship program to try and limit the selective pressure favoring one particular resistance mechanism. Summary box 5.15.
The source lists several key antibiotic types. Can you briefly highlight their main roles, specifically in the context of surgical infections?
Okay, let's run through the main classes mentioned. Keep in mind that antibiotics originally came from living organisms, while others are synthetic. They work in different ways. Some kill bacteria outright, bactericidal. Others just stop them multiplying, bacteriostatic, often by targeting the bacterial cell wall or protein synthesis machinery, ribosomes. Consulting local hospital guidelines or formulary is always essential for specific dosing and usage. Penicillin, specifically benzyl penicillin or penicillin G, still a very useful drug. Good activity against many gram-positive organisms, including most streptococci, like S. pyogenes causing cellulitis, Clostridia used in high doses AV for gas gangrene, some non-beta-lactamase producing Staphylococcus, and organisms like actinomyces. It's the drug of choice for spreading streptococcal infections if sensitive.
Flucloxacillin.
This is a key penicillinase-resistant penicillin. Its main role is treating infections caused by Staphylococcus aureus that produce beta-lactamase, penicillinase, but are not MRSA. It penetrates well into soft tissues and bone, so it's often used for wound infections, cellulitis suspected to be staphylococcal, and osteomyelitis.
Ampicillin, amoxicillin, and coamoxiclav.
Ampicillin and amoxicillin have broader spectrum than basic penicillin, including some gram-negatives like E. coli, Proteus, Haemophilus influenza, and also Enterococcus faecalis, group D strep. However, many gram-negatives like Klebsiella and Pseudomonas are resistant. Coamoxiclav combines amoxicillin with clavulanic acid, a beta-lactamase inhibitor. This extends its activity significantly to cover many beta-lactamase-producing bacteria that would be resistant to amoxicillin alone, including many strains of Staph aureus, E. coli, H. influenza, bacteroides, and Klebsiella. Very widely used.
Piperacillin and ticarcillin, often with inhibitors.
These are extended spectrum penicillins, sometimes called ureadopenicillins. They have very broad activity covering many gram-positives, gram-negatives, including Pseudomonas and Proteus, and anaerobes. They're usually combined with the beta-lactamase inhibitor, piperacillin with tazobactam, known as tazosинzosin, ticarcillin with clavulanic acid, known as timentin, to overcome resistance. They don't cover MRSA, but are used for serious infections like septicemia, hospital-acquired pneumonia, and complex UTIs, often in combination with other agents like aminoglycosides for synergy.
Cephalosporin.
A large and diverse group, often categorized by generations reflecting their spectrum. Drugs like ciprofloxacin, often used for prophylaxis, and cefotaxime, a third generation, are commonly used for intra-abdominal infections, skin soft tissue infections, covering Staph aureus, if not MRSA, and most Enterobacteriaceae, common gram-negatives. Important note. Enterococci are generally not sensitive to cephalosporins. Some later generation cephalosporins, like ceftazidimin, have specific activity against Pseudomonas aeruginosa. Often used in combination therapy, maybe with an aminoglycoside for severe gram-negative infection, and/or metronidazole for anaerobic cover.
Aminoglycosides like gentamicin and tobramycin.
These are primarily active against aerobic gram-negative bacteria, including Enterobacteriaceae and often Pseudomonas. Gentamicin is commonly used, though resistance exists. They are inactive against anaerobes and generally have poor activity against Streptococci and Enterococci. They are known for potential toxicity to the kidneys, necrotoxicity, and the auditory vestibular nerves, ototoxicity. So serum levels, peak and trough, usually need careful monitoring, although single large daily dosing regimens are sometimes used now to potentially reduce toxicity risk.
Vancomycin and teicoplanin glycopeptides.
These are critically important antibiotics because they are active against a wide range of gram-positive bacteria, both aerobic and anaerobic, including, crucially, MRSA. They are often the drugs of choice for known or suspected MRSA infections. They are also sometimes used for surgical prophylaxis in situations with a high risk of MRSA or in patients allergic to beta-lactams. They also require monitoring of serum levels due to potential oto and nephrotoxicity. Importantly, oral vancomycin, which isn't absorbed systemically, is effective for treating C. diff pseudomembranous colitis.
Carbapenems like meropenem, ertapenem, imibinum.
These are very broad-spectrum beta-lactam antibiotics that are stable against many bacterial beta-lactamases, including ESBLs. They have excellent activity against most aerobic gram-positives, but not MRSA, gram-negatives, including Pseudomonas, although ertapenem is less active, and anaerobes. They are generally reserved as big gun antibiotics for serious, life-threatening infections caused by multi-drug-resistant organisms, such as ESBL-resistant UTIs, or severe mixed aerobic and anaerobic infections like complicated intra-abdominal infections or peritonitis.
Metronidazole and imidazole.
An extremely important and widely used drug in surgery. It's safe, well-tolerated, and available in oral, rectal, and intravenous forms. Its key feature is excellent activity against virtually all clinically significant anaerobic bacteria, including anaerobic crocae, bacteroid species, and Clostridia. It's therefore essential for both prophylaxis and treatment in surgeries involving the abdomen and pelvis where anaerobic infection is a risk. It's also a first-line treatment for C. diff pseudomembranous colitis.
Ciprofloxacin and other quinolones.
Quinolones, like ciprofloxacin, are broad-spectrum antibiotics with good activity against many gram-positive and gram-negative bacteria. Ciprofloxacin is particularly useful for its activity against Pseudomonas. However, as mentioned earlier, their widespread use has been linked to increasing rates of C. diff enterocolitis and resistance, so their use is often restricted in many hospitals in the UK and Europe, especially for empirical therapy.
Wow. We've really covered a lot of ground there. We've traveled from ancient history and empirical poultices right through to specific bacterial enzymes like beta-lactamases and the molecular targets of modern antibiotics. We've looked at how the body fights back, how surgery challenges those defenses, and the detailed strategies for preventing and treating infections when they occur.
It's a massive landscape, absolutely. And the real power of this kind of deep dive, I think, comes from connecting all those different pieces together. It's seeing how the history of understanding pus relates directly to modern drainage principles, how bacterial mechanisms of resistance directly inform our choice of antibiotics, how a patient's underlying health fundamentally impacts their vulnerability, and how meticulous surgical technique is often just as important, if not more so, than the drugs we use.
Yeah, it's definitely not just about knowing the list of antibiotics or memorizing bacteria names. It's about understanding the why behind the decisions made by surgical teams. Why timing prophylaxis is so incredibly critical. Why you must drain an abscess. Why mixed infections require combination therapy. Why that patient with diabetes or on steroids is at such higher risk.
Exactly. To truly master this topic, as the elite professionals in this field strive to do, you have to see the entire system in play. The host, the micro, the environment, the intervention itself. It's a dynamic, complex interplay.
So we've made incredible strides since the days of good and laudable pus, armed with aseptic technique, powerful antibiotics, and sophisticated critical care protocols like the Sepsis 6. Yet, as you said at the start, surgical infection remains a formidable foe. It hasn't gone away.
It hasn't. The ongoing, relentless battle with evolving antibiotic resistance, the persistent challenges posed by stubborn, hospital-acquired bugs like C. diff and MRSA, and the sudden appearance of completely novel infectious threats like COVID-19 are constant, stark reminders of that.
So maybe a final thought for our listeners to ponder. Given all these incredible advances, from Lister's carbolic spray to modern carbapenems and intensifier, why is surgical infection still such a major challenge? What does this ongoing battle really tell us about infection itself?
That's a great question. I think it tells us that this is not a battle that will likely ever have a final, decisive victory. Microbes are just too adaptable. It demands continuous learning, constant vigilance, adaptation on our part, and a deep respect for the complex, dynamic nature of the microscopic world and its interaction with us, especially when we intervene surgically. The deep dive never truly ends. It just requires us to keep exploring, keep questioning, and keep improving.
A powerful thought to leave with indeed. The journey of understanding definitely continues.